Let's talk about bone health. Now, bone health is a serious issue. In fact, during my career, I have seen the most dramatic changes in people's quality of life when they fall. But let me share some numbers with you. In the United States, every year, more than 2 million fractures occur every year because of osteoporosis. That includes 700,000 vertebral fractures, meaning your spine, the bone column around your spine, 300,000 hip fractures, and 400,000 hospital admissions. Now, most of these fractures occur in older postmenopausal women. And in women, that risk of osteoporosis that causes fractures increases from 6.8% in your 50s to up to almost 35% in your 80s. That's more than 1 in 3. Now, a fracture may not sound that serious, but hip fractures are associated with a 5 to 8-fold increase in mortality. That means that if you get a hip fracture, you're likely 5 to 8 times more likely to die within 3 months of that hip fracture than somebody else. And the risk of mortality after a year is more than 20%. So it is not a small thing. Now, estrogen deficiency or loss of estrogen leads to what's called increased bone resorption, meaning that's eating up more bone. Your body's eating up more bone and not replacing it with osteoblasts. So increased bone resorption means that your body is taking up bone and not turning it over fast enough, meaning the osteoblasts or the cells that create new bone can't keep up with the bone loss. And this causes a gradual deterioration of multiple types of bone. One is called trabecular bone, and that's sort of porous bone. It's usually found at the ends of long bones, and cortical bone, which is the strong and compact type of bone that's found on the outer layer of the long bones. And so it affects both of those bones. And on average, women experience an annual loss, meaning every year, 2% loss of bone mass, starting 1 to 3 years before menopause and lasting for 5 to 10 years. Now, during the menopause transition, that bone loss is significantly more. There's an average loss of 10 to 12% in the spine and hip. And after that, it sort of slows down to about 0.5% per year. But by the age of 80, the average woman has lost 30% of her peak bone mass. 30%, that is a lot of lost bone. So when you're thinking about screening for bone health, we use a test that measures bone mineral density, and it's called a dual energy X-ray absorptiometry. And it's generally recommended for all women aged greater than or equal to 65. And if you're below 65, 60 to 64, for example, you want to use something called a Frax estimate that would put your risk of a fracture, particularly a 10-year risk of fracture at the same age as a 65-year-old. So how do you know if you're at risk? Well, you may have had multiple fractures before, but essentially talk to your doctor and use this online tool called the Frax tool. I'll put it in the description below and the show notes. Specifically, it measures the 10-year probability of having a fracture, particularly in the hip, the spine, the forearm, or the shoulder. So there's other things that you might do that actually put you at risk too, including smoking and even drinking. In fact, the relative risk of fracture in a postmenopausal woman who smokes increases by 30%. That's independent of bone mineral density. And in terms of alcohol, if you consume 3 servings of alcohol daily, that's associated with a 38% risk increase in osteoporotic fractures and 68% increase in hip fractures. Generally, estrogen therapy is recommended for bone health in terms of prevention. So when we looked again at the Women's Health Initiative, which is the largest study we have on hormone therapy, it has its flaws, but we're not going to talk about those today, that used estrogen and progesterone together, so they had reduced vertebral and hip fractures by 34% in the low fracture risk population. So based on this and a number of other studies, using oral or transdermal, meaning patches or gels of estrogen, are approved for the prevention of osteoporosis. and particularly in young postmenopausal women, so women who are within the first 10 years of going under menopause. Now, systemic estrogen with or without progestin, and the reason you take progestin or progesterone is if you have a uterus to protect yourself from endometrial cancer, it effectively prevents bone loss. And so it's really important to consider this as an option because it really will help you prevent those fractures and those injuries that can be really dramatic and life-changing. It's also important to know if you start hormone therapy and then you go and stop it, the benefits of it change rather quickly. And in fact, the bone loss occurs very fast within 1 to 2 years after stopping, and your protection from fracture or any other sort of injury stops within that first year. So you do need to consider other therapies if you want to help prevent injury. All right, the next topic is joint health. So arthritis, as you probably already know, is really, really common. And in fact, it is one of the most common reasons that people live with disability for years. And arthritis is actually joint-based pain, swelling, and restriction of movement due to the pain and swelling. So estrogen receptors are found in all joint tissues. That includes the articular cartilage, the subchondral bone, and the synovium. Those are all parts of the joint. So to start off, estrogen actually plays an important role in promoting cartilage growth and preventing its breakdown. In fact, researchers have looked at knee joint MRIs of women who are on hormone therapy, and they've actually noticed increased cartilage on their MRIs after going on hormone therapy. So that's one way that your joints benefit from estrogen, but estrogen also helps to decrease bony changes that are associated with osteoarthritis. We've talked about bone health already, so this is another way that bone health is important in your joints. Another interesting thing about estrogen is that it has anti-inflammatory properties. And in arthritis, the joint damage occurs because there's inflammatory signaling pathways that are activated. But estrogen actually acts like a natural anti-inflammatory and helps mitigate some of that joint damage. When you're thinking about how estrogen reduces pain, there's actually a few physiologic mechanisms. First is the estrogen receptors can be found in different parts of the brain and the spinal cord, specifically the dorsal root ganglion, the hypothalamus, the limbic system, in neurons or nerve cells, as well as joints. Now, studies have shown that estrogen therapy actually decreases what we call synovial nerve fiber neurotrophins in animal models. So what that means is they're actually reducing the amount that those nerves fire. And this subsequently actually reduces pain. The other interesting thing is that both estrogen and testosterone have the ability to reduce pain. And they do this by activating specific pain pathways in the spinal cord. So, for example, when estrogen levels are low, like during the early phase of the menstrual cycle or day 1, pain and sensitivity can be heightened, and menopause is a low estrogen phase. So I can actually tell you a story. I vividly remember I was getting laser hair treatment, and I went in, and one day it just hurt so much more than the other days. And my doctor said to me, "It's probably because you're around your menses." And I said, "You know what? That's true." And so it is certainly possible that menopause or having low estrogen states, whether it's through natural menopause or surgical menopause, can heighten your sensation of pain. Also, as we've talked about, all these changes that occur with low estrogen that include fatigue, poor sleep, and mood changes that we're going to talk about next can actually also work to amplify the perception of pain.